Good evening, friends. We welcome you to the PG Clinics webcast. Today's webcast is from Mumbai, Sion Hospital, and this comes to you through an academic grant from Wockhardt Vaccines. Without further ado, we start with the first case, which is being presented by Dr. Lakshmi.
Good evening to all of you present here. Start. My patient is a 5-month-old female child, Anushka, third by birth order, born of non-consanguineous marriage, Hindu by religion, Chaurasia by community, residing at Kurla, hailing from UP, brought by and informed by mother, with complaints of fever since 2 days, cough and cold since 2 days, and respiratory distress since 2 days. The child was apparently normal 2 days back when she developed fever which was moderate grade, not associated with rash, intermittent. The child not active and playful during the interfebrile period, however accepting breastfeeds well. The cough was wet type, not associated with post-nasal vomiting, and was associated with cough in the form of blocked nose. Mother noticed respiratory distress in the form of increased rate of breathing and chest indrawing since 2 days, which is increased since 1 day. On inquiry, the mother gives history of poor weight gain since birth, and there is history of suck cycle in these 2 days when the child had fever, cough and cold. There is no history of sweating over the forehead while feeding, no history of bluish discoloration of the skin, no history of swelling over the feet, no history of decreased urine output, no history of puffiness of the face or abdominal distension, no history of repeated respiratory tract infections, no history of COTS or COTS contact, no history of congenital heart disease in the family. Past history. The child was admitted in Sion Hospital at 2.5 months of age with complaints of respiratory distress but no fever, and the respiratory distress was noticed by the pediatrician when the child was taken for the second dose of DPT and hepatitis B vaccination. The child was treated, kept nil by mouth for 2 days, given IV medications and symptomatic treatment which included nebulization, and discharged after 8 days. A 2D echo was done, and the parents were informed about the child having a heart disease that would need surgical treatment. And the child was also started on oral medications and was advised to take medication regularly and follow up. Family and socio-economic history. The father is 28 years old, studied till 8th standard. He is a clerk, earns rupees 10,000 per month. The mother is 24 years old, studies in the has studied till the 8th standard. She is a homemaker. They have 3 children, the first 2 being twins. 4 years old, healthy, and my patient is a third child who's 5 months old. 7 members living in a chowl, single room, poorly ventilated, no separate kitchen, common toilet, belongs to the upper middle socioeconomic class according to the modified Kuppuswamy classification. Birth history, ANC registered at a government hospital in Kurla, ANC uneventful, received iron and folic acid supplements, 2 doses of TT injection, 3 USG scans done, which was normal. It was an elective LSCS done in view of previous LSCS in view of twins. The mother had received 2 units of PRC transfusions in view of anemia at the 7 months of gestational age. Baby cried immediately after birth. Birth weight is 2.75 kg. There's no history of NICU stay, and the mother and child was discharged 8 days later. And the baby has been exclusively breastfed till now. Developmental history. There's neck holding achieved at 3 months of age. The child can roll over. Fine motor mein the hand regard is present. The child tries to reach out for objects. The child turns head to sound and there is cooing. Social smile. There is social smile and the child recognizes the mother. Immunization history. The child has received only BCG, OPV, hepatitis B, DPT and OPV first dose. Dietic history. Exclusively breastfed 6 to 7 times per day. 6 to 7 times during the day and 2 to 3 times during the night. Adequate urine output 5 to 6 times during the day and 1 to 2 times during the night. That's about the history.
We'll just try and fine tune it a little. So let's come to the presenting complaints first. So you said fever, cough, breathlessness, cough and cold and breathlessness for 2 days. So everything is for 2 days.
Yes, sir.
Yeah. So now when you get such a history, we've discussed this many times. First of all, that cold. So what is the importance of that cold? We've discussed it many times. What is cold and what is the importance of that cold?
The cold could be either in the form of runny nose or a blocked nose. So, with just a nasal suction or a decongestant drops, if that respiratory distress could be attributed to the cold. So, it might not be a significant
More importantly, see, we need to be very sure whether there is a cold. We need to, patients that also tend to talk in one flow, cough and cold. And we also tend to talk and assume in one flow, cough and cold. What is important is that if there is a cold, if there's a genuine runny nose, then if it is associated with significant fever, it indicates a viral infection. So that's very useful in deciding what is the cause of the fever, right? And the second thing is, if there's not much fever, then you wonder whether this is an allergic situation in any child, not necessarily in this 5-month-old child. But absence of cold straight away with the presence of other things like cough and breathlessness straight away takes you to a lower respiratory tract. So that has a lot of localization value and also in terms of etiology. Okay. Now,
would you just summarize for those who have just come a little late? Okay. Just short summary.
My patient is a 5-month-old female child who's third by birth order, who's brought with complaints of fever, cough, cold, and breathlessness all since 2 days. Breathlessness increased since 1 day. The child has a significant past history of being admitted for 8 days in view of breathlessness, but without fever or cough, which was noticed by the pediatrician when the child was taken for immunization. And a 2D echo was done, and the child was told, the parents were informed about the child was said to have a heart disease, which needed surgical management. And the child was given oral medication, which was told to be taken regularly and follow up.
Fine. So I think let's forget the past history. Okay. I want some of you to tell me, if there was no past history that you knew, what you would have done. 5-month-old child came with fever, cold, cough, and breathlessness. You get the point? Past history, she said, the pediatrician said there is a heart disease. Okay, so that takes away all the fun of discussion. And he may not be right also to call it a heart disease. He thought it was a heart disease. So let's not get bogged down there. So how would you go about? Would somebody talk about it?
So fever, cough, cold, and increased respiratory activity. In any case, we will still like to rule out whether the increased respiratory activity is cardiac or respiratory. In any scenario, if a child comes to you with fever, cough, cold, or increased respiratory activity at 5 months of age, the first question for breathlessness is to discriminate whether it is respiratory activity is cardiac or respiratory. Now, if we do not want to take past history.
No, we don't want to.
No, we don't.
So what we are trying to ask you is, forget this child at all. Take a 5-month-old who comes to you with fever, cough, cold, breathlessness for 2 days. This is the presenting complaint. What is your approach? What questions you want to ask? Analyze each thing, and what is your approach?
Which symptom came first? Whether cold was first, whether fever was first, whether cough was first. Which thing came first?
Why? Very good. So why do you want to?
If cold came first, it indicates it started with a viral illness. It like it has upper respiratory tract.
It could be a prodrome of a viral illness.
Prodrome.
Yes.
If fever started first, but it's quite an early thing. But if fever started first, in 2 days, we can still think of a bacterial thing. First came as a fever, then cough, and then increased respiratory activity. That rhinitis can be like, we can ask how much specific it was and how much specific the cough was.
Which is what we were discussing just now.
Come to the conclusion. So this can be the approach in this case. Now another thing which can be that is whether the child has an tendency to have increased respiratory activity, whether she is having an hyperreactive airway disease, which has been triggered by this viral infection. So this can be another way to think on it.
Very good.
We are impressed. Okay, I'll put another situation now. This child is an exclusively breastfed baby and has been always in the family. Now, if she comes with fever, cold, cough, there is no history of similar illness in the family, exclusively breastfed, staying inside the house, not meeting with the community. Now this child comes with fever, cold and cough. What does it mean? You get my question? In other words, this child is not one who should come like this. This is exclusively breastfed. Why infection? Has not gone into the community, stayed in the house. There is no family member with similar viral illness. Now, how will you say what must be wrong with this child? You get my question? Yeah, because you did so well, so I want you to start. Then others will join. Oh, there is somebody who wants to say. Very good. So we'll give him a chance, then you add on. Yeah.
In an exclusively breastfed child with such an unexposed environment, if at all such a significant fever illness which is localized to the respiratory system has occurred, we would like to think of any underlying systemic disorder. It can be either in the form of a cardiac disease or in the form of any underlying malformation of the lung. It may be something related to a primary immunodeficiency which is predisposing this child.
I think wonderful. We are very happy to see how both of you have been discussing this problem. So let's go ahead.
Now I'll ask you something in a different way. So this fever, cough, cold, breathlessness, can this be bronchiolitis in a 5-month-old infant?
Can be.
Fever, cough, cold, breathlessness for 2 days. Can it be bronchiolitis?
Yes.
Yes, it can be. Fever, cough, breathlessness for 2 days in a 5-month-old. Can it be a pneumonia? Bacterial pneumonia? Yes. Fever, cough, cold, breathlessness in a 2-month-old. Can it be a congenital heart disease? Yes. Now tell me, how will you differentiate? Same symptom complex, superficially.
Bronchiolitis will be a well-grown child.
Okay.
Who is not having any other problems. A well-grown breastfed child who is gaining weight nicely, we can think of a bronchiolitis.
Okay, but that's the common thing. But what else? In specific to fever, cough, breathlessness, will you sort of fine-tune it?
In a bronchiolitis, the tachypnea will be the main presenting complaint.
Very good.
Fever is not a predominant feature.
Very good.
In a cardiac disease...
And what about cough?
Cough may or may not be there, but main
Very
presenting feature is tachypnea.
Okay.
That is the main concern for our parent.
Excellent. So what he has said is chief complaint will be breathlessness. Either parent will complain or doctor will notice. So most prominent is breathlessness. Fever is usually mild, sometimes may be high. Cough may or may not be prominent. So let's finish this. When is cough prominent in bronchiolitis and when is it not? Does it have any significance? You have 2 children with bronchiolitis. In one who's coughing badly, another one with bronchiolitis is not coughing. What is the difference? Any significance to us? So what is cough? What does cough indicate?
Cough indicates the involvement of airways.
So one who's coughing badly is... So he has extensive involvement of airway.
But
Means
is bronchioles not airway? Bronchioles is also airway, no? Then why are you trying to say that one who has got a airway involvement is coughing, but bronchiolitis is airway?
Maybe involvement of major airways from...
larger airways. Very
So
good.
he's trying to say very small airways cannot make the pressure come up to cough. That's why interstitial disease, bronchiolitis, don't cough. So now this bronchiolitis is coughing. What do we mean by that? That's his question.
Sir, any illness will progress. The incoming will be from up only. So only major airway involvement and not involvement of lower airway. How is it possible?
So what you want to say is that this acute bronchiolitis who is coughing has also bronchitis. Major involvement. What does that mean? Bronchiolitis doesn't have bronchitis. But this bronchiolitis seems to have also bronchitis. So he's coughing badly. What does that mean? That means
severity of the disease. It is means the infection has spread to the major airway.
But how can it spread from below upward?
he's asking how can it spread from below upwards. Okay. So it means that this is a hyperreactive airway disease which is triggered by a viral infection. Okay, that's the point he's making.
Yeah. So that's the difference between the bronchiolitis who coughs and the bronchiolitis who doesn't cough. Okay. Now tell me, in a pneumonia, how will this same symptom complex be a little different?
Fever will be prominent and of much higher grade, and the localization has occurred very acutely, so it is more likely to be a bacterial. So a fever will be more prominent, and cough may
Noisy breathing.
So also bring in that
Yes.
what noise he is making, right?
Now, you said this baby was discharged at 8 days. Why?
The mother said he was getting IV antibiotics twice a day. He was kept nil by mouth for first 2 days. Then he was given IV antibiotics and symptomatic treatment for fever, cough, and nebulization.
No. At birth.
At birth, it was an LSCS. So, and it was a private setup. So
Okay. Okay. Could you have got a clue at birth that this child will develop a heart disease? Does a left to right shunt have a murmur at birth or on day 1, day 2 of life?
No.
No. Still, can there be a clue? Tachycardia, why? When will you get tachycardia in a left to right shunt? Once the hyperdynamic circulation sets in. So has it set in already? So what could possibly be a clue?
Associated anomalies.
Okay, so if there are associated anomalies, you search for a heart disease. What is the normal physiology of the hemodynamics?
Rajesh, before you go ahead, we'd lost connectivity for some time.
Uh-huh.
So will you summarize what you taught us about the sequence of fever, cold, cough for the three differentials that you came up with?
So we were discussing that the same symptom complex of fever, cold, cough, breathlessness in a 5-month-old infant could be bronchiolitis, it could be pneumonia, or it could be congenital heart disease. But the details and the sequence and the prominence of the different complaints will fish out the diagnosis. So we said in bronchiolitis, tachypnea or breathlessness will be the main complaint, and fever is usually mild. Cough may or may not be there. When cough is there, prominent in a bronchiolitis, we usually suggest it signifies that the involvement is of other anatomical areas of the lung, suggesting hyperreactive airway disease. In a pneumonia, fever will be the chief complaint, followed by breathlessness. Baby will be quite sick.
And cough will come later.
Cough will come later. And in a heart disease, there will be other clues that the baby will be either always tachypnic, baby would have not grown well, there could be increased precordial activity. So all these clues will tell us that this could be a cardiac thing.
And there's one question in which they are asking that, can you say that a child has got a hyperreactive airway disease at 5 months of age?
No, we can't say. We are trying to just explain that why we see a spectrum of bronchiolitis. So the pure viral bronchiolitis, which is a viral infection, usually doesn't cough. But we get some bronchiolitis who cough badly. So these are the ones who are to be followed for hyperreactive airway
in these cases,
disease.
you become an astrologer and predict to the parent that your child is likely to have frequent episodes.
And they are the ones who so-called come for recurrent bronchiolitis and sometimes to different pediatricians, and each one calls it bronchiolitis, and every 2-3 months their child has a similar episode.
I just want to make a point that yes, you can predict that there's going to be a hyperreactive airway if the susceptibility stands. For example, a preterm, a low birth weight baby, or neonatal lung damage, meconium aspiration, RDS, ventilated babies, all are likely to get into a repeated coughs due to hyperreactive airway. Hyperreactive airway
Also behaves like a non-atopic
absolutely.
hyperreactive airway.
Non-atopic hyperreactive airway could be caused by congenital heart disease, congenital malformation of the lung, and all aspiration syndromes, GERD, palatopharyngeal incompetence, delayed development child who has swallowing problem. So all those are non-atopic hyperreactive airway disease. I think you want.
Almost simultaneous occurrence of cough and breathlessness in a small child is uncommon.
Yeah.
They will have symptom sequence. Child comes for cough, fever, cough, aaj se khansi, aaj se breathlessness, more or less simultaneously warns you that we are dealing with something which is pre-existent. More often than not, there could be a heart problem, or if there is a respiratory problem, lung problem, there was already compromise in physiology. And this was just a tipping of the mechanism, so the breathlessness came very fast as compared to the long sequence that we will have.
Very, very important point sir has made. See, cough and breathlessness coming or starting together is always airway. And therefore, fever and cough and breathlessness coming together is very funny combination. So, cough and breathlessness coming together is always airway. Now, that airway can be through way of congenital heart disease, by way of back pressure and pulmonary fluid collection and causing the airway to get involved. So, therefore, this is sir said that even though in that 2 days it's difficult to fish out the sequence, but still you have to fish out. If cough and breathlessness is almost so together, then it's not the usual pulmonary thing.
Often the congenital malformation of the lungs don't have a cough as a feature. Look at a congenital lobar emphysema, just increasing tachypnea. So that's another point to keep in mind. They are not coughing simply because the airway is not involved. And I think therefore only tachypnea could be more likely a respiratory disease as well. But if there is a cough and also tachypnea, then you are sure it's less likely a respiratory problem, much more likely a cardiac problem.
Then a family history helps. If the child belongs to a family which has hyperreactive airway, then you pick them up. Then these children have atopy, they have dry skin and other things. And often they have leaky eyes. We call it blockage of nasolacrimal ducts. I feel they over leak, they produce excess of water in the eyes because of the overreactivity.
So Rajesh, you are telling us that doing origin, duration and progress of a simple thing like cough, cold, fever can tell us what we are going through.
A lot of things. So I was on what is the normal hemodynamics after birth with respect to the signs in the heart. So can anyone talk of that? Because my question was what clue.
Basically, the closure happens.
Okay, let me come to the point.
So
on
correlate with clinical signs.
On day 1, is the second heart sound split? On day 1 of life. Pointed question. Yes or no?
No, sir, because of pulmonary hypertension is
so on day 1 or 2 of life, some amount of pulmonary hypertension is normal. So there is no difference. So the second heart sound is not split. In a normal baby, by day 3 roughly, the pulmonary pressure will fall and the split second heart sound will be seen. So in a normal baby, ideally on day 3 when a normal baby is discharged, a split second heart sound is reassuring. In a baby who has a left to right shunt, the body delays this fall of pulmonary hypertension. So what would have happened on day 3 takes 8 to 10 days to happen, and therefore if this baby particularly was discharged on day 8, now on day 3 it's difficult, but if on day 8 you find that the second heart sound is not yet split, you know that the pulmonary pressure has not yet fallen, means something is fishy. So that is a technique, is a possible clue.
Of course, that also would happen in a fallows coming up, a single heart shunt. So what he's trying to say is that it may not tell us whether it's a left to right shunt, but it will tell you that there is some heart disease coming. Because the fellows also would exactly come the same way, that 4 days have passed and the second sound is still single. So, but just because we are talking about second sound, who will describe what is normal second sound split? So, what is normal second sound split?
Because of closure of
I know that, but will you describe how does the clinician see a second sound split? Can it be split throughout the cycle? Can it be split throughout the respiratory cycle, or it's not?
Expiration, you can appreciate it more in a better way. Sorry.
Normally the split will be heard only in the inspiration, and in expiration there will be no split normally.
That's right. And I think this is important to make sure that what you mean by widely split. Widely split is split during both the phases of respiration. Otherwise you can't say how wide it is, and that is widely split. So difficult to kind of assess in a small baby with a tachycardia, but yes, you must know the physiology correctly, that when you say widely split, you mean to say both inspiration and expiration, the second sound remains split. Yeah?
One question on this. We normally discharge all the babies of normal labor on day 3. So is it like that while auscultating, if you find this difficulty, how often is the possibility that the child is having a heart disease?
So it depends
How much
on
to follow
both.
up?
It depends on both. One is your competence to judge the second heart sound, because some of us may not be able to make out the split even at 20 years of life.
Rajesh,
Forget day 3
also
of
your
life.
inclination to look for the second sound.
But I mean, I personally feel that once you have practiced doing this on 10 or 20 normal newborns, it will not be difficult. And if you look up the books also, when you document that you are discharging a baby, what all you have to document, in that if you document that the second heart sound is split, it makes a big difference.
See, clinically, yes. I know it's very difficult. Now, like the second sound, even the right ventricular heave. Okay, if you find the right ventricular heave, you know that the right-sided pressures have not fallen down. But the answer to your question is, that's why now in many centers, and today echo is a normal screening test for all newborns, because the incidence of congenital heart is 1%, 1 out of 100. It's so common. So today some centers do it. There is a debate whether you should do it cost effective, etc. But some centers do it as a routine, like routine neonatal screening for varieties of inborn error of metabolism, at least the hypothyroid, the G6PD.
Similarly, they do pulse ox of all 4 limbs before
So
discharging
now this
the
is
baby.
becoming, yes, because it's not easy for most of the clinicians, including RNME, to pick up so well, right? And in Western countries, the newborns are discharged even on day 1, because it's not cost effective to keep them for 3 days. So it becomes cost effective to do a 2-day echo and a pulse ox, which is cheaper than staying them in the hospital for 2 more days. So that's, I think, the thing. But your question is valid, how easy it is to pick up. It's very difficult.
In order to comment on the newborn's heart, the baby should be absolutely quiet. So quiet. If you touch the baby also, in a second the heart rate goes up. That means when the baby is brought and the baby is just kept, before you do anything to the baby, your first action should be to lightly put the stethoscope on the heart. And even if you open and remove the heart rate goes up like this. Another important thing may be that by day 7, the heart rate must come down to 120. 140 to 120, 140, 140, 160 also. But if the baby is absolutely quiet, 1 day has passed, if there is no left-right shunt significant, it must come to about 120. In a very quiet baby sleeping nicely, and I have touched the baby without intervention, I still find dardur. That is not so common. I would like to pay more attention. And when you concentrate on second heart sound, often you have to concentrate. Sometimes you hear second heart sound with respite, sometimes you don't. You may not be able to time it with inspiration because the heart is so fast and the inspiration, the respiration is so fast. But kabhi kabhi sunta hai, kabhi kabhi, most of the time it is single. But sometimes you are able to hit, appreciate two elements of element, that is good enough to call it a normal.
It's like a knee jerk. In your 5 attempts, you get one knee jerk, means knee jerk is present. So same way in 60 beats, if you hear 2 beats which were split, means it is split. It's that way. Okay. So now we think that this baby, even though the pediatrician said, but after our analysis, what do you think this baby has? Forget what the pediatrician said.
So, but suck cycle is not very significant of because this child also had suck cycle during these 2 days of respiratory distress and fever and cough. On
so
inquiry,
it is significant, but provided you have got your history correctly. So, we have discussed this many times. What exactly did you ask and what did the parents say for you to conclude that there is suck cycle?
I asked if the child was comfortably able to suck onto the nipple. So she said because she would get.
Sorry, madam, not nipple.
I was about to.
Okay, the child was comfortably breastfeeding. So the mother said the child would get tired, and so she would stop feeding for some time and then suck on and again breastfeed. So it was not normal because earlier the child was comfortably feeding, but once this cough, fever and breathlessness started, the child would stop and again feed. But the child was feeding and with adequate urine output.
If child is not getting milk, also child will do the same.
But
we'll try to suck, not getting, come out, cry, again try, hoping that next time it will come.
But
so
2 days back,
suck, rest, suck. Okay, almost telling me that sucking makes you breathless and a rest makes you recover from breathless. Okay, whereas a child who is not getting enough milk from the breast also goes to the breast, cries, comes out, goes again. So, what is your comment to that?
If that was
I know
the case,
that
okay.
we take it for granted. When you tell me the history, the parents don't know suck cycle at all. So you interpret already. That's why I was asking what made the parents say something that you interpreted it as suck. That is this question.
See, 2 days back, so that's actually another topic. So that is not what your suck should rest on, that 2 days back he was fine, And secondly, you actually mentioned that the pediatrician noticed that the baby was tachypnic. That means the mother had not noticed. So which means that this baby was tachypnic much earlier. So that's a point I wanted, that your history should be a little more refined to ask that when did the parent first notice the tachypnea, if at all. Right? Because if the baby was already tachypnic at 2.5 months when the baby went for vaccination, that means there would have been feeding difficulty even before that. There could have been. So we need to ask that. We need to ask for the growth of the baby as perceived by the mother for those first 2 months also.
She said there was no problem. I asked her. She said there was no problem breastfeeding, but the weight gain was poor.
Okay. So baby was able to feed. Okay. So now how will we sort out this suck? So as sir said, literally you should be able to gather from the history that when the baby starts feeding, baby feeds, gives 5, 7, 10 sucks and then leaves and then is visibly breathless. Even a lay mother can make out that त्याला दम लागतं आणि मग तो 2 मिनिटं थांबतो, मग दम जरा कमी होतो and then he starts feeding again. That is perfect suck cycle.
Could you please translate what you just
Sorry.
said in Marathi?
So the mother, the lay person would actually, even a lay parent would say that the baby became breathless while feeding and therefore gave up feeding, and then the parent can see that the baby is breathless. Then after 2-3 minutes the baby settles down a little and then starts sucking.
Tell us, how is this different from the breathlessness in a bronchiolitis? Same thing would happen, no?
Come, so you all
But,
answer this.
breathlessness in a cardiac disease is much more. It's because the respiratory rate is much higher compared to
Not
that.
necessarily.
It's a difference of 20. Cardiac disease respiratory rate is 60. Bronchiolitis it is 80.
Child with a bronchiolitis is basically very tachypnic. So for him, it's very difficult to suck.
Doesn't start feeding only.
Very good. Very good.
And rest doesn't make him better also.
Very good. So both ways. It is not that first the baby will be able to suck if really very tachypnic, and if able to suck, then if not able to suck, then rest doesn't help. So both ways. So that's the difference. Yeah. Okay. So now finally, so what is your analysis in this child? How would you sort of summarize what you have gathered in this history in 4-5 sentences?
A 5-month-old female child who is partially immunized was brought with complaints of acute onset of. Okay.
Summarize the interpretation of whatever we have discussed so far of this history. So 5-month-old, full-term normal delivery, apparently normal at birth, has come with a history suggestive of what?
History suggestive of involvement of the suggestive of lower respiratory tract infection with an underlying congenital acyanotic congenital heart disease.
So why lower respiratory tract infection? The first one was no fever, so no infection.
But now.
So first infection, no?
The lower respiratory tract infection with an underlying congenital heart disease.
Correct. So what makes you say congenital heart disease?
Okay. Because of the suck cycle
and
the past history, a significant past history of breathlessness without fever and cough.
So there is history suggestive of increased pulmonary blood flow and history suggestive of dyspnea on exertion in the form of a suck cycle, and then now a lower respiratory infection in a 5-month-old breastfed baby. So this is what tells you that this is likely to be a left to right shunt with increased pulmonary blood flow.
Increased precordial activity, if present, is definitely a sign of heart. That will not occur in breastfeeding. And many mothers are able to say that there is dhar taking place. So dhar will not take place if the child doesn't have a cardiac heart. So you can ask for either dhar hota hai. They understand and appreciate the increased precordial activity which is there in the baby with congenital heart. So additional point which will in the thrill, you directly alight at the anatomy where the thrill is. If you have a increased precordial activity, it's a significant point in favor of a cardiac problem.
I think now we all know it's a congenital heart disease. Can we guess what disease it is? First convince me it's a cyanotic or acyanotic. Yeah. If it's a cyanotic, convince me shunt or no shunt. And if you convince me further, which one? Let's see how the good history can even fish that out. Okay. So is it cyanotic or acyanotic?
It's acyanotic. It's acyanotic. Because...
yeah, go on.
Because there's no history of bluish discoloration of the skin.
So could the parents have missed noticing the cyanosis?
But breath hold features
of increased pulmonary blood flow would not have come in a cyanosis.
Sorry?
Right. Features of increased pulmonary blood flow would not have come apart from a few cases like TGA. But
correct. So there is one group of cyanotic heart disease which have increased pulmonary blood flow.
But that would have been cyanotic from the beginning. And the doctor would have noticed cyanosis more than the tachypnea.
See, doctor is as into inverted commas as the parent. So if parent can miss, doctor can also miss. Okay. And in fact, the group which has increased pulmonary blood flow is the group which will have milder cyanosis. So that's the one which will be missed actually. Deep cyanosis will not be missed. Okay. So what is your answer to that? Come on. Come on. We've discussed this
Sir,
earlier
in this
also.
child, the first manifestation, whatever it is noticed by a doctor or whoever at 2 months of age, it is suggestive of once the pulmonary pressure has gone down around 6 to 8 weeks, then the manifestation have started. So one possibility it could be left to right shunt. That is the one possibility. With acyanotic, cyanosis has been never been noticed. Now, second episode, the child has presented with fever, cough, and breathlessness. Is suggestive of that the scent is increasing. Means the pulmonary plethora has been set up in this episode. So it's suggestive of again left to right shunt.
So probably what we could answer is that the group where there is increased pulmonary blood flow, that group of cyanotic heart disease comes with failure and mild cyanosis, right? So that mild cyanosis, sometimes it is possible to miss, but that group will have prominent symptoms of failure all along. So that is why it is less likely, but you cannot like stamp and say that that group is not possible. But the other two groups are not possible. Which are the other two groups? The groups with parallel circulation, like TGA alone, pure TGA. That is deep cyanosis on day 1. So that is not possible. And fallows, which is obstructive pulmonary lesions, will come up with cyanosis later. And because they are decreased pulmonary blood flow, they will not come up with these symptoms of failure and all this. Okay, so that group is also not possible. But that middle group is theoretically possible, but symptoms of failure will be more prominent and therefore it is less likely. But I would like to confirm on examination. Right?
They should have presented much earlier in life and more severe manifestations.
I think all that you would say is that largely commonly are cyanotic, but rarely also cyanotic. So by incidence, you have very high chance of cyanotic than otherwise, but you can't rule that out. Other thing is that if cough is a predominant feature, then there is a left to right shunt. Look at the TAPVC or a PAPVC. They will behave exactly like an acute bronchiolitis. There won't be much cough but tachypnea. Whereas the left to right shunt will have much more cough in symptomatology and also tachypnea. So again, make a small difference. Look at the TAPVC coming exactly like an acute bronchiolitis sometimes. So when you see an acute bronchiolitis, keep in mind whether this is going to be fooling you like a TAPVC. And the only difference would be a good clinical examination. Acute bronchiolitis would have largely an emphysematous chest with cardiac dullness and hepatic dullness impaired. Okay. So we will say that by commonness, it must be a left to right shunt, more so because this child has got a history of cough. But otherwise, both stand to be there. And we will not hurry through to say it's not a cyanotic heart disease. Yeah?
Besides left to right shunt, so forget cyanotic now, we've talked about that. In acyanotic, besides left to right shunt, do we talk of something else or it's only left to right shunt?
It could be valvular lesions also.
Very good. So which
valvular? Valvular lesions could be either stenotic or regurgitant lesions. So
in this situation,
aortic.
In this situation, we are not talking of stenotic lesions. These symptoms, if at all, are of regurgitant lesions.
Aortic regurgitation.
So, AV valve regurgitation, which is part of AV canal defect. Okay? So, how will you differentiate that clinically? Small things, may not be like sacrosanct, but still. So, AV canal defect will have more failure and will come early. Correct? So this child has come, like he said, at 6 to 8 weeks and also less likely to be AV canal defect. Any other group which can come with similar symptoms of pulmonary overload? Volume overload? Cardiomyopathies. Okay. So cardiomyopathies again can come with volume overload of the lung. But again, they will be not so rapidly progressive probably, and they'll be slower in their manifestations. So theoretically, first your branching should be cyanotic or acyanotic. Within acyanotic, left to right shunt, regurgitant lesions or cardiomyopathies. And then within left to right shunts, further you discuss the three shunts that we commonly see. So VSD, ASD, PDA. So now which of these do you think is possible in this child?
VSD is the commonest acyanotic.
Besides that,
Uh,
any other reasons to say why this is likely to be VSD and not ASD and not PDA?
and ASD manifests in adults
very
more. If it is ASD is
ASD will manifest either in the very initial days of birth or it will manifest late, at like after 7 years or 8 years. In the adolescent period. So ASD is less likely, and VSD because it's typically in the period when the pulmonary hypertension is just dropped, and that was the first time when the child developed that cough and breathlessness first episode. So more likely to be a VSD.
And what about PDA?
PDA would have presented early, sir. Means the baby would have stayed in NICU, or baby would have presented breathlessness or tachypnea much earlier, or on clinical examination the signs must have come up, or murmur would have come up if it is a PDA.
So clinical examination is still to happen, but again risk factors, so whether this was preterm or term, so those things would make that more likely. Okay, come, we'll examine the baby. Who wants to volunteer to examine? Take the chair here. इधर सुलाएंगे तो रोएगी कि ओके साइड करो थोड़ा चेयर इधर सॉरी आप एक मिनट उठिएगा बैठिए
इस साइड में सर कर दो
So whoever is speaking, take the collar mic so that your hands are free to examine.
For a 5-month-old child, this appears to be a visibly malnourished child. Child is irritable, not very sick looking. Head to toe.
Mild tachypnea present, subcostal retractions present, and intercostal retractions also present, but the child is comfortable. There is no hyperdynamic, there is no precordial bulge or any signs of any hyperdynamic circulation. No visible precordial pulsations in epigastric or
Pericardial bulge is present with prominent of um, costochondral junctions on the left side as compared to right. The right also it is present, and there is a slight Doug is there. Because of it could be suggestive of the tachypnea could be quite longer duration. It is not
Liable.
of acute duration, and overall look of the child is a failure to thrive. Means not for 5-month-old child he is showing lots sort of wastings overall on inspection with
no evidence of any dysmorphic facies.
And no cyanosis as such.
No visible cyanosis.
What other anomalies you should give a negative history of?
Radial.
So no anomalies in the upper limbs.
There is as such there is no even white congenital cataract.
The posterior fontanelle
No
is
cleft
closed.
lip.
The anterior fontanelle is open to 2.5 by 2.5 centimeters.
PF is open still.
Now quickly do the CVS examination. Take the opportunity that the baby is quiet. Don't go for the stetho directly. First use your hands.
There is a thrill which is felt at the fifth intercostal space on the left side, which is suggestive of a grade 4 by 6 systolic, mostly pansystolic kind of a.
Okay, I think we'll just take the findings from her. It's okay. Aye. Want to take Gautami? Want to send her? Yeah, tell us the findings.
The child is examined. Child was examined in the supine position, comfortably in the mother's lap. The child was at the time of examination. The child was mildly febrile with a heart rate of 126 beats per minute, respiratory rate of 44 cycles per minute with minimal subcostal retractions. The child looks undernourished. Pulse was normal in volume and rhythm. No radioradial or radiofemoral delay. Peripheral pulse is well felt. The SpO2 was taken of all the 4 limbs. No significant difference. And the NIBP was normal. It was within 4 limb NIBP was taken. It was within the normal range. Head to toe examination. The skull is normal size shape. Frontal bossing, mild frontal bossing. The eyes appear sunken. Anterior fontanelle open 2 to 2 centimeters. Posterior fontanelle closed. Hair and skin normal. No facial dysmorphisms. Spine, limbs and genitalia normal. No signs of vitamin deficiencies. Anthropometry. The weight was less than minus 3 standard deviation.
What is the weight?
It is 3.6 kg. The birth weight was 2.75 kg. Systemic examination, cardiovascular
length
is 62 centimeters. It's more than the plus 2 standard deviation.
More than plus 2? How can it be?
Because
5-month-old 62 you are saying.
Minus 3 is 51 centimeters.
No. There's something
normal
wrong with your check. You've mixed up something. What is the normal length of a 5-month-old baby?
At birth,
around
it's
62 to 65, sir. 62 around 62 to 65
Even
centimeters.
64, 65. 64, 65, 5-month-old baby, normal length. Okay? There's some mix-up that you have done. So 62 is this baby's length. And head is?
Head circumference 38 centimeters. That is between the -1 and median. That is in the median.
I have a suggestion. While you talk of standard deviation and your Z-scores, must quote the actual value. You may say below third standard, but first you must quote the actual value. That weight is this much, and then you give your comment.
Weight
Length
is,
is this much, and then you give. Otherwise, there is wide range, and we don't know where the child is falling.
Okay. So.
Okay. So 3.6 kg, 62 centimeters, and
38 centimeters
38
head circumference.
Okay.
Chest circumference 35. Mid upper arm circumference 10 centimeters. Systemic examination, cardiovascular system. On inspection, there's mild precordial bulge. There are no engorged veins or visible pulsations. Apex beat is present in the fifth intercostal space in the mid-clavicular line. Palpation, findings of inspection were confirmed. Apical impulse diffuse but best felt in the left fifth intercostal space, just lateral to the mid-clavicular line. Hyperdynamic in nature. There's a palpable P2, no parasternal heave. There's a thrill best felt in the along the lower left parasternal area.
So now just stop here and analyze your findings without auscultation.
So the precordial bulge would suggest the disease. It would say that the disease is of a long duration, not an anything of acute. It's not an acute onset disease, and cardiomegaly.
So cardiomegaly with hypertrophy. That is why there is a bulge. Okay. So the cardiac muscle is forcefully contracting and pushing the soft chest, and therefore there is a bulge, right? Okay, then?
And there is a hyperdynamic apical impulse that suggests of hyperdynamic circulation, volume overload.
Okay.
And the apical impulse is in the left fifth intercostal space, lateral to the mid-clavicular line. So normally in this age group, it should have been in the fourth intercostal space, lateral to the mid-clavicular line, but just lateral. Now the apical impulse is pushed down, the apex is pushed down and out to left ventricular hypertrophy, suggestive of left ventricular hypertrophy.
So far what you have got before auscultation is that you have a congenital heart disease. It is chronic, that means it has been there for some time. You said there's cardiomegaly, you said there's left ventricular hypertrophy, you said there's volume overload. What else?
No
There's
visible
a palpable P2.
Palpable P2. So there's pulmonary hypertension.
And there's a thrill.
And there's a thrill. Where is the thrill?
In the lower left parasternal area.
So what does that signify?
Thrill, it is a palpable murmur. So
what is the importance of a thrill as against
the grade
a murmur?
4. Okay.
Underlying disease, then it is a anatomical defect.
So thrill is usually always thrill signifies that the problem lies anatomically underneath that spot. So what lies under? Yeah. What lies there?
Left
parasternal. What
area,
lies there?
Right ventricle.
Interventricular
Septum.
septum.
So what I'm trying to explain is that even before auscultation, your diagnosis is almost complete. You've got all the elements. You've got a ventricular septal defect, you've got pulmonary hypertension, you've got LVH, you've got cardiomegaly, you've got volume overload. So you've got everything, even though you have not yet reached auscultation. Okay. Now tell us the auscultation finding.
Auscultation, so the S1 was normal. There's a loud S2, and there's a pansystolic murmur, loud and best heard in the left parasternal area, harsh, radiating to the axilla and the opposite side of the chest, not radiating to the back. So area-wise, the pansystolic murmur was heard in the mitral and tricuspid area. It was best heard, lower left parasternal area, and pulmonary area. There's a loud S2. So
okay. Anything else? Anything else that is
Grade
important
4
and relevant to this child? So one, any other murmurs? Second, any other sounds?
I could not appreciate.
Yeah, but would you look for something?
You can get a heart split.
Anybody? Mid-diastolic murmur where?
Pulmonary area.
At the apex. What would it tell you? it's a flow murmur. So the presence of a mid-diastolic murmur at the apex tells you that the shunt is significant. Okay, the QS by QP could be more than 2:1. Okay. Okay. Then anything else on examination?
No, so the spleen was just okay, that's about CVS. Per abdomen, the spleen was just palpable, but when the child came, the liver is just palpable. When the child came, the liver was around 4 centimeter, and there was bilateral creps and decreased air entry in the left lower lung fields. Now there's just conducted breath sounds on RS.
Fine. So what's your final diagnosis?
5 months old female child with 5 months old female child with pneumonia, with acyanotic congenital heart disease, with a left to right shunt, with increased pulmonary blood flow, in sinus rhythm, presently not in failure, in a developmentally normal and partially immunized child, to rule out VSD, the aortopulmonary window.
So if it's a VSD, would you like to qualify it further? Would you use an adjective to describe?
Large.
What is the adjective that you use that makes a big
muscular,
difference?
Large muscular VSD. Pulmonary vascular, with pulmonary vascular, increased pulmonary vascular.
Restrictive or non-restrictive?
Okay.
That's the key word to be used. So what is this? Restrictive or non-restrictive?
It is non-restrictive. Restrictive is a small, normally less.
Correct.
Less than 0.5 centimeter square per meter square of body surface area.
So this is a non-restrictive.
And in restrictive, you get just an early systolic murmur, because it's not dependent on the pulmonary vascular resistance.
In restrictive, you will not get so much of hyperdynamic circulation and LVH and all that, and you won't get so many symptoms. Okay, fine. Any particular reason why you brought in AP window?
The DD is for VSD is present.
Or maybe you know the echo findings, that's why you brought it. Okay. Anyway, so now how will you investigate this child and how will you treat this baby?
Investigations, because the child came with fever, cough, cold. We did the routine baseline investigation, CBC, RFT, serum electrolytes, and a chest X-ray was done. ABG, we would like to do an ABG.
So how would you answer that? In
Rajesh,
now,
there seems to be some problem. How can you have a harsh murmur and call it a large VSD? So that is what needs to be explained. You've got a thrill, you've got a harsh murmur, which will be seen in smaller size VSD. So why is she saying this is a large VSD? He may be underfed because
loud. It's not harsh. It is a loud murmur.
You felt a thrill, no?
Haan.
So the VSD has to be small. If it's a large VSD, then you will not feel a thrill. There will be no restriction to the flow. There won't be vibration.
Okay.
Small VSDs are harsh, they are louder, and they don't have a loud second heart sound. We need to understand that. There is some inconsistency. I'm not saying that your findings are incorrect. I'm just saying that there seems to be more to it than just this.
So who wants to take that up?
It could be medium sized VSD, sir, moderate size, or with some amount of pulmonary stenosis. That can explain.
That can explain what?
Having a loud murmur with.
So you mean the murmur is due to the pulmonary stenosis?
No, murmur is due to moderate VSD, and means I mean to say that right-sided pressures means during systole there is some amount of pulmonary infundibular stenosis. It providing resistance. When the systolic contraction happens, left ventricle contracts, there is a blood flow between left to right. But because of that stenosis, it must be not easily flow.
Then second heart sound should be soft.
if he is suggesting of a pulmonary stenosis and that too with a moderate VSD, I think there is no business there to be a murmur also. The left and the right pressure might be quite equal. So there has to be no murmur at that juncture, that too with thrill.
So you are agreeing with me or disagreeing with me?
He is disagreeing with his theory that pulmonary infundibular stenosis is one explanation. He is disagreeing with that.
As long as he's not disagreeing with me, it's fine.
So now you want to answer Anand's question? He is saying that because there is a thrill, this can't be a non-restrictive VSD.
Or it could be switches.
If there is right to left shunt occurring, means progression of the disease, then it will.
No, why
Means
do we bring in right
in left
to
to
left?
right shunt, if there is large and pulmonary vascular resistance increases, means pulmonary hypertension is developing, and because of that, if the Eisenmengerization develop, then it will be.
Then what will happen?
Then the murmur will disappear. Means
We are saying murmur is very loud. That's not being explained.
So there is no reason to bring in the.
I think what Anand has brought out a point is that you expected the VSD to be, if at all, smaller, because there is a harsh murmur, there is a thrill. And then the symptomatology does not suggest a small VSD, but suggests much more large VSD. The point to make is that large number of VSDs are not just simple VSDs, but a complicated VSD. And whenever you diagnose a VSD, especially look for something that would tell you that this is a complicated VSD. It may be with ASD, it may be with whatever. And I think VSD is one lesion where there are many times associated lesions. So this is one good way to say that I thought this was a moderate to large VSD by symptomatology, but by clinical examination, I get the VSD which is smaller. Then why are the symptoms so big and the VSD clinically so small? Which means that there must be something beyond VSD that probably is causing this trouble.
Upon examination for a small VSD, again these two things are different. Only it's like your parasternal heave, your precordial bulge, all this again suggests that the VSD, in a small VSD you won't get this much thing.
So that's the point I'm making.
Sir, could be possibility of multiple VSD, like twisty.
So that's the point I'm making, that my clinical examination by murmur said it must not be a large VSD, but the other findings and the symptoms suggest it must be large. When there is the discrepancy like this, consider a complicated VSD. And as you said, there may be multiple VSDs, there may be VSD with ASD, whatever. And I think that's an important point that is coming out of this. Therefore, the diagnosis could be a complicated VSD on clinical examination.
So, a subtle difference, the signs that tell you that there is a VSD or the signs attributable to the septal defect itself are the thrill, location of the thrill and the murmur. But the parasternal heave and the cardiomegaly and all that are not signs of VSD. They are the signs of consequence of left to right shunt over a period of time. They are not signs of VSD. So that's the difference that we have to make, right? Okay. So I think about investigations, always I thought we should make a habit that specific investigations to confirm this diagnosis would be ECG, X-ray chest and 2D echo, and general supportive investigations would be CBC and all that. Okay. Now, how will you manage this child?
So I would, because the child came in failure, when the child came, the child was in failure. So decongestive measures with Lasix and Envas. I mean, the child was actually on Lasix and Envas. When I inquired into the drugs, they had started the child on Lasix and Envas. So I would like to continue that. And we would not rush in for a surgery because VSDs, they tend to close. But here, since the symptoms are, so we'll have to wait for weight gain, and then we'll have to see if the symptoms are not settling with decongestive measures, then we'll have to operate. So
Okay, so anybody
The ideal
else
age
has
is 2
any
years,
other way to answer that about surgery?
As child is already failure to thrive, it is less than third percentile. So mostly we should proceed for surgical management of the VSD, as child is not growing well at present with this.
No, so she is saying that this failure to thrive is because the child was in failure. So if we treat the failure medically, then where is the need to operate? Just wait for the VSD to close.
As this VSD is also complicated VSD and large size, so most probably it will not spontaneously.
Large size we don't know yet. We were debating whether it's small or large.
Like a complicated VSD most likely will not close spontaneously.
Okay. So basically,
You wanted to say something?
Same view, sir. Means
So
it is because
what
of
else did you get which is worrying you in this child?
failure to thrive and
Okay.
baby and
Pulmonary
hypertension.
absolutely.
So this child will require surgery.
Absolutely. So, if an infant has pulmonary hypertension, this is an indication for surgery, even if you are able to control failure with medical line of therapy. Right? Then you don't wait. Because why do you not wait for surgery?
because once the pulmonary artery hypertension becomes irreversible, then
Exactly.
there is no,
So you don't allow it to be long-standing and irreversible, because that then becomes a contraindication
For
to surgery,
surgery.
right? So that's why this child would probably need surgery. Of course, as he said, you need to confirm the exact diagnosis on a 2D echo before you decide on surgery.
So what was the echo finding?
so we'll just look at the X-ray before the. So large mid-muscular VSD with a left to right shunt, dilated left atrium and left ventricle, moderate PAH, good biventricular function. Large 10 mm non-restrictive mid-muscular VSD with left to right shunt, possibility of additional apical VSD, normal biventricular function, aortic and pulmonary valve normal. The flow related increased gradient, normally related great arteries, no PDA, moderate PAH, no coarctation of aorta, left ventricular ejection fraction 60%.
Fine. You said you wanted to see the X-ray.
I thought this, yeah. This is the AP view. Exposure pretty good. Mildly rotated film. There is obvious cardiomegaly, and there is increased bronchovascular markings with a cardiothoracic ratio of 0.6. And is hepatomegaly.
Can you really talk of hepatomegaly on that? Instead, what else will you say?
They push down.
Push down. So for why?
Because normally it had to be felt in the fifth.
Correct. So you are seeing more number of intercostal spaces. So what does that tell you?
So it's an inspiratory film and hyperinflated chest.
Hyperinflation. So this is a breathless child. What else is there on the X-ray to tell you this is a breathless child?
Air.
Too many air shadows in the bowel.
Abdomen,
So this is a tachypnic breathless child. Okay, and okay. What about the heart? Anything more you want to say about the heart shadow? Cardiomegaly you said. What else?
There's the left ventricular hypertrophy.
So left
It's almost
ventricular
occupying a
hypertrophy.
hemithorax. So
Then what else? So 2-3 important things you should try and say.
prominent
So you should
pulmonary
look at this convexity here, and if you see
Left
this convex,
atrium.
then that's pulmonary artery dilatation. Then you should try and see if you can see the aortic arch in all congenital heart diseases. Okay, so try to look at the shadow of the aorta, aortic knuckle. Try to look here. I don't think I can make out, but you try to look for that. This normally you get a concavity here, which if it is convex, then it tells you that there's a pulmonary artery hypertension. Okay, comment on the right atrium if you can, whether you can see. So you said it's a rotated film, so you cannot. Normally you see a small amount of right atrium here, which you can't see on this. Okay, so these are few things that important that you must comment on the heart X-ray. She said, sir, she said pulmonary vasculature.
So after seeing the X-ray, are you convinced you want to do an early surgery? So what features on the X-ray are telling you that you should operate this child fast?
this cardiomegaly itself is
And
the bronchovascular marking.
And the pulmonary
Pulmonary artery,
conus. So all these tell you that are you happy about something? Are you worried that were you worried that there could be Eisenmengerization as was suggested, but those signs are not there? So that's one thing which is telling you that you still have time to operate and get this.
What's the prognosis? So after surgery, will this child be bang normal? Anybody? So if this child is operated before irreversible pH sets in, so like this child is now 5 months old. So if this child is operated soon and is a well operated child, he could be as normal as a normal child. Okay, and that's why it's very important to get the surgery done in time. Okay.
Thank you very much. I think the next case is being presented by Dr. Amol.
Good evening, everybody. So, my case is Unnati Jadhav, 10.5 years old female child, first by birth order, second of the twin delivery, resident of Chembur, hailing from Ratnagiri, Buddhist by community and religion, and was brought by informed by parents with itching complaints of fever since 10 days. Chest pain since 4 to 5 days, cough since 4 days. Patient was relatively alright 10 days back, after which she started having fever, which was high grade, intermittent, associated with chills, not associated with rigors, rash or convulsions, more in the evening, temporarily responding to the medications. Child was active and playful in the interfebrile period. Patient started having chest pain since 4 days in the left lower side of the chest in the frontal aspect, which was localized and increased on coughing and on deep inspiration, and was relieved by taking rest. No diurnal variations were observed. Patient also started complaining of cough, which was non-productive, non-spasmodic, intermittent, with no diurnal or postural variations, and was associated with chest pain. There's no history of breathlessness, no history of sore throat or rhinorrhea. There's no history of easy fatigability or palpitations or edema feet. There is no history of recent weight loss, no history of hemoptysis. There's no history of tuberculosis or tuberculosis contact. There's no history of trauma, no history of skin rash or joint pain. There is no history of similar complaints in the past or in the family members. The past history, there is history of chicken pox that the child got 2 years ago. There is no history of any other major illnesses in the past. There is no history of any admissions or surgeries in the past. Birth history is uneventful. The patient was registered for ANZ checkup. Patient was delivered by full-term normal vaginal delivery. Baby cried immediately after birth. No NICU stay now. The patient is immunized till date. Developmentally, all the developmental milestones were achieved at appropriate ages. Currently, the patient studies in the 5th standard and is average in studies. Dietary-wise, the calorie requirement is 1580, the intake is 1310, so there is 270 kilocalories deficit, and there is a protein deficit of 7.4. Family history, the father is 37 years old, educated to 12th standard, BMC worker, servant by profession. He earns 20,000 rupees per month. He has a history of seizure disorder and is on oral anti-epileptics from KM hospital. The mother is 33 years old, 10th standard, educated up to 10th standard, and she is housewife. There is one sibling, a twin sister to the patient. Socioeconomically, the patient belongs to middle class of the modified Kupuswamy scale. So that's about the history. On.
No, what is salient features?
So what are the salient features?
So the cough and the fever since 10 days, chest pains in 4 to 5 days, and cough since 4 days.
Okay. So how will you analyze this history? We've got maybe half an hour for this case, so let's quickly analyze and move ahead. Anybody wants to try? So
I think he has summarized it quite. Fever, then chest pain, which is increased on respiration or
no. So first tell me, chest pain came 5 days back, no, and fever for 10 days. Correct?
Yes, sir.
So till 5th day there was no chest pain. So what would you have thought just before chest pain came up?
Till 5th day.
So first 4 or 5 days there was only fever, no chest pain, no cough, nothing.
Right.
How would you think on that 4th or 5th day? Then chest pain came tomorrow. So first till 4th, 5th day, how will you think?
So high-grade fever with chills. So high-grade fever with chills. So malaria, basically A5, malaria, dengue, acute febrile illness.
1 minute. Don't enumerate the causes. So malaria.
Yeah.
So now, do you think it is malaria? Would you have given him anti-malarials? Tell me for, against, pros, cons.
The child was active in the interfebrile period.
Which means what?
Which means
Take a mic and speak, please.
It was definitely not serious bacterial infection if this child was well in between.
So, look at the way Amol is saying. He is not saying playful interfebrile means viral. He is saying not serious bacterial. There is a difference between the thing. So, not serious bacterial. So, it could be viral, it could be malaria, it could be immune mediated, it could be anything. But not serious bacterial. Okay, what else? So, now for malaria, would you have given him anti-malarials at this point?
Yes, I would have given if the patient had come in that stage.
Okay.
Based only on history.
Yeah. Any other possibilities? Do you think this could be viral infection?
So what Rajesh is asking on the behavior of the fever for 5 days before chest pain started, can you think of what is the disease process? Think of that. So how would a viral fever behave? How will a bacterial fever behave? How will malaria behave? How will typhoid behave? Think of those and then answer his question.
Anybody can volunteer. Yeah, take.
A viral fever will be a high grade fever to begin with, and child will be normal during.
It's on. Keep it close.
A viral fever will be a high grade fever to begin with. Child will be normal during the interfebrile period. For a bacterial fever,
What else? Which is often there in a viral, which is missing here.
Coryza.
Generalized involvement. So besides fever, there is nothing else. Okay. And again, these are small things, not very important, but you said chills and rigors. So I would have probably gone into the details whether chills and rigors all throughout or only in the beginning or what.
Okay.
It has very little value, but even those small things. So influenza can start with chills, but then we'll start with headache, body ache, running nose, sneezing, so many other things, right? Otherwise, it is uncommon for a viral fever to start with chills, right? So, okay, go on. And then all those things are not there, cough, cold. Then
but the bacterial child will be a sick child. It won't be a high grade fever to begin with. It will rise, except for the entry site fever. The bacterial will be always will get. For it.
So why is this not, say, tonsillitis or dysentery?
Again, the child is not sick during the interfebrile period.
And
there is no history suggestive of localization in
there
this
is
case.
no history of localization of those
I would keep
bacterial
at the back of my mind that
infections.
whether I am dealing with non-infective causes of fever, I mean non-viral, non-bacterial.
Very good. So because this child started with high fever, even with chills for that matter, and because it is not a irregular pattern, malaria is not prominent, bacterial, as we said, is not sick, so less likely bacterial, viral we have said no, so therefore you would also think of a non-viral, non-bacterial cause even at this stage before chest pain or before any other symptom came in. Right?
Right.
Okay. Now you want to bring in chest pain?
Yeah.
So what does that mean? That means pneumonia.
Don't get scared of him. He's like that only. You say what you want to say.
High fever for 5 days with chills followed by chest pain is pneumonia.
There's no history of breathlessness.
Very
Cough
good.
is
So
not
there's
there.
no history.
It is left-sided, no? Pericarditis. There is a pneumonia here. Left-sided is said.
So the history of chest pain which he has elicited, it is at the peak of inspiration. So that is suggestive of pleural involvement, which comes at the peak of inspiration. So it is a pleuritis kind of a chest pain.
Right. So first you answered that no pneumonia because there is no breathlessness, to which sir said it could be pericarditis. So one is the character of the pain suggests pleura. What is the pain in pericarditis? How is it? Describe. Continuous and what? Where is it?
Retrosternal.
It is retrosternal, so it is midline, not on the left side. Okay, left side only in Hindi movies.
I think this is the pneumonia starting, no? Breathlessness will come. Pneumonia is starting. See, fever, now you are localizing. You wanted a bacterial infection to localize, it has localized now. Now give some time, he'll get breathless. Pneumonia has to really come in the way of an adequate pulmonary function. It is just beginning now, no? So now I will call it an early pneumonia. Oh, first class. You have diagnosed very early.
Distribution of the symptoms, like it's generalized pain or localized pain over the lobe of the left lower lobe of the left upper lobe or left lower lobe, or it's a generalized signs. Will differentiate. Generalized signs only will suggest a pleural.
Signs will come later when we examine. Just now sir is asking that why is this not a early pneumonia?
So which pneumonias have chest pain is what we are asking you.
Yeah, but why is this not a early pneumonia? Why?
So pneumonia will there be parenchymal involvement, and there will be no pain. If there is pain, then it will spread to the pleura. Then it will be the extensive and other signs of the.
That's what she's trying to say. This disease seems to have started from pleura. She made a statement, it is a parenchyma that at times is also involving pleura, therefore has a chest pain. Not all pneumonias are. So histopathologically all pneumonias are Histopathologically, all pneumonias are pleuropneumonia. But clinically, many pneumonias are no pleuropneumonias, only pneumonias. Because there has to be a significant inflammation of a pleura to cause pain for a clinician to call it pleuropneumonia. Whereas a histopathologist sees microscopic inflammation of a pleura. So what she is trying to say is that pleural pain is not an early sign of pneumonia. And therefore by now he would have been breathless as well. So this is a primary pleural disease. Whereas pleuropneumonia is primary parenchymal disease in which a covering of the lung, pleura, may also be involved. You get this clearly? Therefore it is not pneumonia. Then what? It is pleuritis. So have you heard about pleuritis? What? Staphylococcal pleuritis, streptococcal what? What is this pleuritis?
Allergic pleuritis, like a non-infective inflammatory.
So you mean a rheumatological disorder?
Immune mediated.
It could be immune mediated.
So rheumatological disorder.
Yes.
So what? Systemic onset GI with pleuritis or an SLE coming up, female child. So what is that? Pleuritis is a part of an immune disorder.
It can present as isolated immune mediated.
Other serosa.
There are no other
markers suggestive of any rheumatological involvement.
You will repeat that whole thing again.
There are no other markers suggestive of any rheumatological involvement. He made it a point to say there is no rash, no joint pain.
So only starting primarily with chest pain and no other manifestations is less likely. Okay, there may be associated or if there is a small amount of pleural effusion in a long-standing fever, then it is just a diagnosis made on investigation. He may now no pleural effusion on clinical examination, but he has prolonged fever and then on examination or 2D echo, you find that there is small amount of fluid around the pericardium, small amount of around the pleura. So we call it there is little ascites, so we call it polyserositis. So the child has gone to long fever, polyserositis, maybe high ESR, WBC count high, platelets high. So we think of a systemic inflammatory disorder, but they are not the primary manifestations as early as this.
So then what is the cause of this pleuritis? So autoimmune is ruled out.
Tuberculosis
Then what?
can tubercular.
And therefore you would have said that this is an inflammatory pleuritis. Inflammatory pleuritis of two types. Autoimmune, that's what he discussed, or infection-induced immune. Okay. Now, which is a common infection that comes with such an inflammatory disorder, so it becomes tuberculosis, right? So I think that's the way you would have arrived at that. But I'm sure the kidney disorder may be the first manifestation of an immune inflammatory disorder. So it's not that organ involvement may not be the first manifestation, but a pleural disease as a first manifestation is unlikely. But surely a nephritis could be just an SLE, the first episode, and you have nothing else to go by, and something will develop over time. So I think we take a note that while local findings in an autoinflammatory disease, organ involvement are known, pleuritis is not known. That's why this is not going to be.
Rajesh,
Yeah.
there seems to be some confusion here. Can you clarify why you're not thinking of an empyema? I mean, we discussed it, but there's a question. So, why are we not thinking of empyema?
So, as I think some of the students answered, that empyema has to be after a pneumonia. It's a complication of a pneumonia. And as some of the students answered, this child does not have pneumonia because this child never became breathless. So there was a febrile illness followed by straight involvement of the pleura without anything to suggest involvement of the parenchyma. So as sir said, this is a primary pleural disease and that's why not an empyema. Empyema never happens that a bacterial infection directly primarily involves the pleura. Bacterial infection first involves parenchyma and then spreads as a complication.
And even our fever pattern was not suggestive of a bacterial infection.
Yeah,
it started
hectic,
with
yeah.
migraine.
Empyema would be hectic high fever very poorly responsive, very sick child, toxic child. Okay, fine. So let's examine the child.
So you agree with what we have discussed? Do you agree with all this?
Yeah.
So one question here. If it's a tubercular effusion, it has to be a large effusion. It cannot be a mild effusion which will cause so much of pain and
In fact, a mild effusion will cause pain. Large effusion will not cause any pain.
Because
That's
it separates the
so that's
both
what-
parietal as well as visceral pleura, as the amount of fluid gets accumulated in pleural space.
So the pain reduces.
Yes,
So,
sir.
but
And the child gets breathless because of that. No.
So, but here the child is having pain.
Yeah, so it has to be a small effusion.
Correct. So
Tubercular effusion has a generally large effusion.
Not necessarily. That we'll see on examination.
I think every immune reaction depends on the host immune functions. Okay. You are describing a very healthy child who gets a tuberculous pleural effusion. He doesn't come much with pain, but he comes with a breathlessness because of a large effusion. But if the child is not all that immunologically competent, but not immunosuppressed either, so you can see the whole spectrum. So this child ought not to be the well-nourished child. Had it been a well-nourished child, this child would have exactly come with a large effusion, and breathlessness would have been the only symptom, and a chest pain would probably have never come up, because the fluid accumulates very fast, and there is no chance of a patient feeling pain. Much before that happens, the effusion has come up and the breathlessness has come up. But this child must not be well nourished, therefore she is not throwing up a large effusion, but she is probably throwing a small effusion. And that small effusion means some layers of the pleura are still together, sticking together, and that's causing pain. But over time, suppose she starts getting well nourished, yes, she is going to get rid of pain. Maybe the effusion may even increase. So that's the question. In fact, you're right that if this child was breathless and having pain, we would have started saying, no, there is something wrong. She can't be breathless if she had pain. And therefore, this child is not breathless. That's why it is so. You will still may find a small effusion, yes, but that won't be large effusion. In fact, dry pleuritis is not common. It's also known. And dry pleuritis is difficult to make out, just the pleural rub and nothing else. But most of them will have a small effusion. And therefore we expect the findings of a small effusion in this child.
does she still have chest pain?
She still does have like the chest pain has decreased, but it is still present, as she said. Yeah.
Okay.
The point is, why did you consider a pleural thing? Could it be a costochondritis? You get pain on deep inspiration. Why are we suddenly getting into...
Please take the mic.
Unilateral, sir. I mean, if it is costochondritis, it could be bilateral.
No. Costochondritis is a localized disease.
You get
It
knee
is
pain, you can
unilateral.
get on one side.
It is unilateral.
So presence of fever.
Presence of fever, yes, infective costochondritis, no? Typical. Why did you go inside for a pain to look at? Look at outside. I'm sure there is a local tenderness and a swelling too in this child. It must be a costochondritis.
No relation with respiration.
After all, a costochondritis, yes. After all, when you take a deep inspiration, the whole ribs are moving, no? You get pain there also. So now why did we just say that it is pleural pain only?
Child will able to point with fingers. This pain is pointing over the desk costochondral junction.
Yeah, so costochondritis pain will be localized by such a child, to point out that this is where it is paining, okay? And plus, that pain may worsen on inspiration, but it will still be there. Whereas this pain is as described or as elicited, this is when the pleura rub that she gets pain. So
and that's why I also ask what happens to the pain on changing position of sleeping. If she sleeps on the side of the pain may not be felt. Costochondritis pain
will be
all
worse.
Okay, so I think small difference. Costochondria is a rare disease, but we just want to be sure that why did you run into pleura only, right?
Sir, in the sequence
Sometimes
of
there
events,
be not much of fever and only one-sided pain, and after 4 or 5 days, some eruptions may come, unilateral pain, and then it is herpes zoster.
Yeah. And that pain is typically a burning type of a pain and a severe pain, intolerable pain. I think that's a very bad pain. And in fact, if you have a bad pain localized, again, it's getting localized to the nerve root. But it's an extremely severe pain and even pain at rest, etc.
sir, in the sequence of events, the fever is since 10 days and the chest pain has started only since 5 days. Will rule out costochondritis, and chest pain would have been the much more prominent symptom.
Absolutely. It would have started with a pain there.
Then the
Good
inflammatory
point to make. Fever, pain would have come almost together. Yeah. Very good.
Yeah, tell us the findings.
Yeah. On examination, patient is conscious, cooperative, well oriented with respect to time, place, and person, and is comfortably lying on bed, now sitting. Patient is afebrile. Pulse rate taken at right radial artery 118 per minute, regular, good volume, normal character, all peripheral pulses well felt, no radial or radiofemoral delay. Respiratory rate 34 per minute, regular, thoracoabdominal, no distress. Blood pressure is 100 by 62 millimeters of mercury in right arm supine position, so it comes to around 50th percentile.
So comment on the pulse rate and the respiratory rate.
Pulse is normal.
118 for a 10-year-old child at rest, afebrile.
It's a bit tachycardia.
So why? So note that this is definitely abnormal for this child. Now it could be pain, it could be anxiety, it could be, you'll have to find a cause for it. But 118 for a 10-year-old at rest, and when you are mentioning afebrile, it's definitely abnormal. So don't be caught on the wrong foot. Check your 118 again. Okay. And 34 respiratory rate.
44. We checked it's 44.
Yeah, so just now we think it's 44, but when you checked, you said 34. But even if it's 34, what is your comment?
It's tachypnea is there.
Tachypnea is there. Okay. And then you said no distress. Correct? No distress means no use of accessory muscles.
Yeah.
So what does that tell you?
Tachypnea without distress, metabolic acidosis. What else is it?
Anxiety.
Anxiety is causing the tachypnea.
Hyperventilation.
So in other words, tell me whether if there is tachypnea without any retractions, what does it mean physiologically to you? So one is no parenchymal involvement. What else? Airway? Very good. So the airways are also not involved. So in other words, it tells you that there is nothing wrong with the compliance of the lung. There is nothing wrong with the airways. There is no upper airway or there is no lower airway obstruction. But still the child is tachypnic, which means what? Where is the pathology? So either pleura or, as Anand said, one situation is acidosis. So in other words, what I am trying to explain is that in pleural pathology there are no retractions. Okay? Because there is nothing wrong with the compliance of the lung. There is no difficulty in expanding the lung. There is no obstruction. There is nothing. So
you think because the child is breathless, this is a large effusion? Or there could be another reason for this fast breathing with a pleural pathology?
Avoiding pain.
Excellent.
Shallow breathing.
So it's not necessary that it's pain, but it could be to avoid the pain, shallow breaths.
okay.
Okay. The anthropometry wise, weight is 24.8 kg, height is 130 centimeter, which is between -1 to -2 standard deviation, and BMI is 14.67, which is between -1 to -2 standard deviations. So according to anthro, the child is undernourished. On examination, skull is normal.
Skip all that.
Okay.
Come to positive findings.
Okay. There are small hypopigmented spots on the body, which might be due to the history of chickenpox 2 years ago, and there is some insignificant lymphadenopathy on right side of cervical. Others are normal. So the system examination, respiratory system inspection, trachea is central, shape of the chest is normal, no fullness is noted, respiratory movements are decreased on left inframammary, infraaxillary and infrascapular regions, no scars, sinuses or dilated veins, and apex impulse was not visible. On palpation, inspiratory findings are confirmed. There is no local warmth or tenderness. Apex beat is felt in left fifth intercostal space in mid-clavicular line. The chest movements are decreased at left inframammary, infraaxillary and infrascapular regions. The tactile vocal fermitus is decreased in the same regions, left inframammary, infraaxillary and infrascapular regions. On percussion, patient is non-tender percuss. Dull note is present in the left inframammary, infraaxillary and infrascapular area. Other areas are apparently they're resonant except for the cardiac and liver dullness. On auscultation, air entry is decreased on the left inframammary, infraaxillary and infrascapular region. There is no adventitious sounds heard. Vocal resonance is decreased in the left inframammary, infraaxillary and infrascapular regions. On cardiovascular system, heart sounds are normal, no findings of cardiomegaly. Abdominal is soft, non-tender, no organomegaly, no evidence of free fluid. CNS, tone, power and reflexes are normal, no meningeal signs.
So what is the interpretation of your physical signs?
It seems to be left pleural effusion, the findings.
Why? Why can't it be a pneumonia with an overlying effusion or a sympathetic effusion? So first tell me why effusion.
So there is a dull note on percussion,
which can be there in a pneumonia. It can be there in a collapse. Anybody, come on quickly.
Vocal resonance will be increased in consolidation and it will be decreased in pleural effusion.
Provided it's a pure consolidation. Suppose there's a consolidation with a synmnemonic effusion, then still the vocal resonance will be increased.
There will be bronchial breath sounds if there is a
all those will be lost because of the overlying fluid.
Shift of trachea?
Shift of trachea happens when?
As is showing a pleural distribution of the signs, as left upper lobe and left lower lobe also is involved, means there is a pleural kind of involvement, then is lobar distribution.
Excellent. So more than the signs, the distribution of signs. So like you rightly said, it is left inframammary, infraaxillary and infrascapular. So this is not seen in any lobar pathology, and that is why this is pleural, and then you say it's a pleural effusion, right?
Why do you call it pleural effusion? You only say that there is a pleural lesion. To me it's a thickened pleura. There is no effusion. After all, I understand that it's a pleural disease. And then impaired note, diminished air entry, no foreign sounds. So we are clear it's a pleural disease. I will call it a thickened pleura or a pleuritis. Yeah, there is a chest pain. So pleuritis. After all, the pleura is inflamed. Inflamed means swollen. Swollen means there is a diminished air entry, impaired note, no foreign sound. Where is an effusion? There is no shift of the mediastinum. No. There is no effusion.
Pleural thickening
Trachea
should be
is not shifted. Apex beat is not shifted. Why do you call it effusion?
So pleural thickening should be uniform and it should involve the entire
Thick
pleura.
and pleura, yes. After all that you know is a pleural disease. I agree with that. And a pleural disease without any mediastinal shift is not effusion to me. It's only a pleuritis.
So there's one sign visible just now which is
that's
telling you.
Pleural effusion.
Tachypnea. Excellent.
There is tachypnea, therefore it must be an effusion. Right?
Okay, so difference between a thickening and effusion. Okay, fine. So it's a pleural effusion. Possible etiology?
The way it presented, it's just 8 to 10 days of history of fever and high grade fever. It can be bacterial.
So we discussed in the history, no? So what you should say is that this, as sir said, that word is very important. This illness has primarily localized to the pleura without involving the underlying lung as per our clinical history and findings. So we expect underlying lung to be normal. Bacterial infections don't primarily involve the pleura. Okay? So therefore it could be immune mediated as seen in tuberculosis. Theoretically it could be viral, but we don't see that very commonly and therefore not bacterial, that's for sure.
But there can be a differential diagnosis of that, isn't it? To me it's a malignancy. She's looking pale. Okay. It's a malignancy.
There is no history of
pleural effusion is all right. Malignancy. You get high fever, yes. You get a short duration, yes. Why tubercle? Malignancy.
So malignant will be sick child. This is
So this child is not an acutely sick child. Plus, the typical malignant pleural effusion is a very sick-looking child with significant pallor. There is a blood collected there. This child did not look sick. Okay, and I think that's the point. So you give a differential diagnosis. Okay, and one of the differential diagnoses is a pleuroendothelioma with a pleural effusion. But in this child, because she is not very sick, that's why.
How will you confirm your diagnosis?
I would like to investigate. Firstly, I will indoor the patient. I'd like to.
So Rajesh, you are saying this physical examination is not going to tell me the diagnosis. I'll get the diagnosis on the history. Is that what you just told us?
So that is crucial to the diagnosis. Physical examination will only confirm the anatomy. But the process, the circumstantial evidence for the etiology is through the history.
I'd like to do the X-ray, CBC. I'd like to work up for. I'd like to do the Cox workup. I would like to do if the CPC turns on platelets are normal, then I would like to do the pleural tapping and see the routine microscopy and culture sensitive pattern.
What is the Cox workup?
Cox workup. There are 5 things that workup for tuberculosis. There are five things are associated are present in that. One is chest X-ray, ESR, sputum AFB, Mantoux, and USG abdomen retroperitoneal lymphadenopathy, RPLN.
Why is sputum primary pleural disease?
And sir, Mantoux in such a old child, 10.5 years.
Yeah.
And why sputum? You broadly said primary pleural disease. Okay, and now you are saying sputum. Why sputum?
So you cannot rule out that primarily.
No, but where is primary is pleura? You said no. You all agreed primary pleural disease.
Immunological process.
And now why are you talking about a parenchymal investigations?
Subclinical focus will be present. Subclinical focus.
So what we say is that primary pleural manifestation of a very insignificant small subpleural tubercle focus. So it's really pathologically a parenchymal disease, but clinically it's only a pleural disease. So clinically a pleural disease, pathologically primary parenchymal disease, but so insignificant, so you will do a sputum. Yeah.
Sir, your comments on Mantoux? What will Mantoux help you with?
Anand is asking that.
So actually the effusion is an immunological response, so you expect Mantoux to be positive. But if you get a Mantoux negative, you just don't throw it out for varieties of reasons. One is, of course, the technique, etc., but that's not a point to discuss. But sometimes when there is some immunological response here to an infection, all sensitized T lymphocytes are busy there fighting. And then a small tuberculin injected there, the immune system says, don't look at that. Just look. This could happen. Generally doesn't happen. Imagine in a police station there's a phone call, there's a bomb blast. So all are dispatched there. And you go and say, but my pocket was also picked. He said, no time. Okay, because priority demands that your pocket, okay, that means no response from the police. Mantoux is negative. This happens rarely. So the point is that if your diagnosis is very strongly based as tuberculous pleural effusion, you just don't walk away saying Mantoux is negative. But yes, make a point that invariably Mantoux is expected to be positive. That's the way to go by. Yeah.
You have the X-ray of this child?
Yeah.
And have you done a TAP, diagnostic
Yes,
TAP?
we had done.
So tell us the report of the pleural fluid. First come and read the X-ray. Show it. उधर लगा उधर.
So it's a bit underexposed film. Yeah, it's a bit underexposed film.
Why do you say that? I can see all the vertebrae right up to the.
So you are saying underexposed because the film is not looking very bright. So that is underdeveloped.
Okay.
But exposure is overexposure.
Okay.
You understood?
No, we are not troubling you. Don't misunderstand us. We want you to say the right things in the exam.
Exactly, sir. So it is underdeveloped film. So it's trachea is central, and we can see the.
Is it a well centralized film?
Yes, it is well centralized.
Look at the clavicles. They're okay? Yeah, I suppose.
It's centralized. We can see this.
You need not. You just go on saying. We can see. Everyone can see. So you go on speaking.
The left CP angle is obliterated.
So you start by saying there is a diffuse homogeneous opacity seen in the left hemithorax, yes. Lower half of left hemithorax. Okay. Now describe that opacity.
That opacity, it is it's.
So what else do you want to talk about the opacity? Is it well demarcated?
It's well demarcated.
Well demarcated. Then what are the
it's curvilinear. It's
yeah. So
shape.
that's a curvilinear border with the lateral edge of the opacity extending upwards.
Upwards.
Right.
Right.
Then do you want to talk about its relation to the heart? So can you separate out the heart shadow from this opacity?
No.
So
heart shadow cannot be separated out of it. It's
so the opacity cannot be differentiated from the
cardiac shadow.
Cardiac shadow. Okay. So what is
costophrenic angle? You say?
Now come and say that the costophrenic angle is obliterated, cardiophrenic angle is obliterated.
Yeah,
okay.
Yeah, we heard.
I had said that earlier.
So when you say separate out from the heart shadow, you can and cannot. There is something known as silhouette sign. So what is silhouette sign? in such a shadow that is important? Anybody? When you see a opacity which is kind of merging with the heart shadow, there is a sign called silhouette sign. What is it and what does it tell you?
It tells us that it can't differentiate the cardiac shadow from the pleural shadow. So it is silhouetting the heart border, silhouetting the cardiac border.
Okay, little better. So when you can differentiate two opacities, when the margin between them can be seen, that means your silhouette can be seen. That means the two opacities are not in the same plane. So either it's anterior or posterior to that. But when you cannot differentiate, it is in the same plane. This is the importance of silhouette sign. So therefore, a pneumonia which is next to the heart will probably, if it is in the lower lobe, the shadow will look similar, but there'll be a differentiation between the pneumonia shadow and the heart shadow. Okay. So here your diagnosis is, this is a, radiologically what's your diagnosis? This is a effusion.
Left pleural effusion.
Okay. Now tell us quickly the TAP findings and then, sorry.
Sir, my silhouette sign is not seen, so there could be a pneumonia also, which is just adjacent to the heart. Because otherwise there is only pleural effusion. I can see this, but I can see this also. Either the pleural effusion is anterior to the heart or posterior to the heart, or it's all around. But why should it completely obliterate? So there could be an underlying pneumonia as well in this particular child, even if the etiology is tuberculosis. Because there can be some sort of a shadow here. You can see this particular shadow, and this is a lamellar effusion, of course. But otherwise there should have been silhouette sign should not have been. That's what I was wondering, whether we can still see the heart shadow. No, you can still see perhaps a heart shadow from
Sir, if we probably got a well-developed film, we could make out.
I can still see a heart shadow through this opacity probably. So this gives an impression that it's not, but you see this shadow and there's a differentiation
So,
between
but
these
usually in effusions we are not able to make out separation from the heart and the effusion, because the effusion, like you said, is both anterior and posterior.
I think because the involvement of the pleura, it gives rise to homogeneously opaque picture through which you will not be able to appreciate the underlying lung. The underlying lung will look opaque to you because there is so much of fluid there.
In a partially immunocompetent child, there could be a possibility of a small tuberculous pneumonia and also an effusion. But clinically, that pneumonia will not be seen. That is the point. Whereas in a typical bacterial pneumonia with empyema or the sympathetic effusion, pneumonia is prominent. So this is subpleural small tubercle focus in a big effusion. That's an immunocompetent patient. Partially competent, there could be a subpleural focus which is just enlarging. So radiology might pick it up, and still there is an effusion. So you get the point. Whereas a bacterial pneumonia is a big pneumonia first, and then you fish out an empyema. Whereas here, you pick up an effusion first and try to see whether there is any underlying pneumonia. So the dictum is effusion without pneumonia is tubercle, and an effusion with pneumonia is bacterial. But pathologically, both have pneumonia and effusion, but in tubercle the pneumonia is insignificant to only a radiological small significance. That is what this child has. So even suppose this was well developed, and as Dr. Khare showed that there is some small suggestion of a silhouette, it will be still be called a tuberculous disease and not a bacterial disease.
Sir, and the pneumonia does not manifest because it's a subacute process, gradually growing up, so the body is able to adapt.
See, this is a child with an acute onset pleural disease. Let's call it an acute onset pleural disease. Whereas a pneumonia with empyema is an acute onset of pneumonia which complicates thereafter and presents as a non-resolving or non-responding pneumonia. two things are very different clinically, history-wise. So we have no doubt that this is tubercle.
So, and that tuberculous pneumonia, if it were there, it would be subacute and slowly progressive.
Absolutely. It means in this child, there has to be a tuberculous pneumonia. Only clinically invisible, radiologically mostly invisible. But if you do a CT scan, you will certainly find a pneumonia there. And that's why you had to do a sputum for AFB, even otherwise. Right?
Sonography is done?
Yeah.
Ultrasound?
Yeah. USG was done. That is showing left-sided mild pleural effusion. And there is no retroperitoneal lymphadenopathy as such.
An underlying lung they have commented on?
No, they have not commented
Okay.
on
TAP findings?
TAP findings. The TAP findings was a TLC were 1450 WBC per cmm and poly 20% and lympho 80%. Proteins were 2.4 gram per deciliter.
Actually, even if you had polyps there, don't bother about it.
Yeah.
Even polyps can still make a tuberculous allergic effusion only, so it will not change your diagnosis at all. Just a point that the sonologist may pick up even a small septi, and they will tell you, oh, this is something, don't look at that. After all, it's an inflammation. Whether it's a bacterial inflammation or an allergic inflammation, there is an inflammatory exudate there.
Right.
So small thin septi will be picked up by a good sonologist and almost make you feel that no, your diagnosis is going astray. Don't worry about it at all. Clinical story is strongly important, and therefore it's not rare for a sonologist to report in a tuberculous effusion, oh, there are septi. Don't worry at all. Anyway, he doesn't need a drainage, isn't it? Why does he not need a drainage? The fluid has to come out. It's inflammatory fluid. So the dictum in surgery, inflammatory collection must be drained out.
It is a secondary due to the inflammatory process somewhere else. So if we treat the primary disease,
It will take a lot of time, no? Anti-TB drugs will work only after 2 months. Till then what? Till then it will be chronic disease. Okay, thickened pleura will develop, underlying lung will collapse, all problems will disappear.
This is immune mediated once we
So you
start.
want to give steroids?
No.
Then immune mediated, no steroids.
So even if we drain it, it will recollect. So there is no point of draining this fluid. If it's like
And
a
continuous drain, continuous drain.
Once you start a treatment, it starts resolving by its own, sir, because it is an immune mediated.
So what you are trying to say is that immune mediated disorders typically come up acutely, disappear acutely. So we expect that this will disappear acutely.
You will make only diagnostic tap, or you want to remove more fluid?
If it is causing any significant respiratory,
Yeah,
if it is
if it is
causing
for-
any significant respiratory
The
distress,
tachypnea is there, no? She's
No, but
tachypneic.
tachypnea, but
You
not
convince me it's effusion because of tachypnea. Why don't you tap her dry and make her comfortable?
So it's not causing distress to the child. That was
there is
because
no
of
distress,
pain.
only tachypnea.
Child is not that sick. Not using accessory muscles of respiration. Still child is comfortable. So
One small comment in the pleural effusion, don't forget to look at the ribs. I remember occasionally radiologists showing massive pleural effusion and a small rib erosion, and he called it Ewing sarcoma. Okay, so look at the bone. We always say as a bony cage is normal, well centralized, like cough cold, it all goes on. But you must mean it before you say that.
In fact, in an exam you are shown X-ray of the chest or the ribs as well.
Right.
And a thalassemia can be diagnosed by that. Rickets can be diagnosed by that. And you keep on saying heart, lungs, etc., you forget the bone. So ABCDEF, we have said that. Go systematically, B stand for bones. So in an ABCD of radiology, bones are important.
I think we'll wind up the clinic now.
Yes.
Thank you so much, Dr. Amol.
Thank you, sir.
And I hope we didn't harass you too much.
Not
today.
at all, sir.
We won't be having a broadcast next week.
So we meet, that's because of it being the Diwali week. We meet on the 19th of November, and the session's focus will be on neurology, and we look forward to Dr. Rajesh Udani being the guest faculty. So see you on the 19th. Thank you so much.